Welcome back to the endocrine system. This is video 7 for this particular chapter, chapter 18, spring 2025, Panola College. So in this video, we're going to go over the pancreas. We'll go through the notable disorder of the pancreas, which is diabetes mellitus. And then we will talk about the gonads and some of the more minor endocrine organs. Okay? So, the pancreas is a long, thin gland located posterior to the stomach in the upper left abdominal quadrant. And remember, it's going to function as both an endocrine gland because it secretes hormones that control blood glucose levels, which we will talk about in just a few moments, and also an exocrine gland because it secretes digestive enzymes, notably animalase, lipase, and protease. So those will break down and process carbohydrates, lipids, and proteins respectively. We will learn more about those in the digestive system chapter. So the hormone secreting cells of the pancreas are called the islets of Langerhans. This is a fancy word that means island. And on this island, or this cell group, we have a number of different cells, including the alpha cells, which secrete glucagon, and the beta cells, which secrete insulin. So once again, the alpha cells will secrete glucagon, and the beta cells will secrete insulin. All right. So here's a close-up of some pancreatic histology. We have some more cells to go through here that are located in the islets of Langerhans. So as we stated before, the alpha cells secrete glucagon and the beta cells secrete insulin. We also have gamma cells, otherwise known as pancreatic polypeptide cells, which will secrete pancreatic polypeptide, which will regulate pancreatic secretions, and then delta cells, which will secrete somatostatin, which will actually, I didn't have that animate, but what it will do to GH, TSH, and prolactin is actually going to cause those levels to decrease. So it will lead to the decrease of all those hormones. All right. I think that's it for this here. Okay. So let's talk about the two notable hormones for the pancreas. That is insulin and glucagon. So here, for both insulin and glucagon, when we're talking blood glucose levels, so we're talking a humoral effect here. So we have no hormone coming from the pituitary to stimulate the pancreas to release these two hormones. These hormones will be released as a result of increase or decrease blood glucose levels. So the stimulus for insulin being released into the body is an increase in blood glucose levels. When the body senses that increase in blood glucose, it will secrete insulin, which will come from the beta cells of the pancreas. And remember, this is a humoral effect. Insulin will make its way into the bloodstream and will travel to these areas here, the liver, adipose connective tissue, muscle, and then most cells. In the liver, glycogen is synthesized, while the breakdown of glycogen and new creation of glucose is inhibited. So if we think about this, okay, we have increased blood glucose levels. And when you have increased blood glucose levels, we want to store that glucose and also use it for energy, okay? So what happens is we're going to take this glucose, and what happens in the liver is it's going to be stored. And the way that you store glucose is you store it as glycogen. Glycogen is the storage form of glucose. And since we have increased blood glucose levels, we don't want to break down glycogen, because if you break down glycogen, you're going to increase your glucose levels. We don't want to do that. And we also don't want to create any new glucose because our glucose levels are already high. Okay, so we're going to inhibit the breakdown of glycogen, and we're going to inhibit the new creation of glucose. In the adipose connective tissue, lipids are synthesized. So you see down here, increased lipogenesis, that is the creation or synthesis of lipids, and we have decreased lipolysis or breakdown of lipids. Okay. In the muscle, excuse me, protein synthesis or anabolism is promoted. So we want to create new protein. The majority of cells, glucose is taken up. Okay, so essentially what is going on is we are either going to store glucose, or the cells are going to take it up and use it for energy. Okay, and so the storage of glucose will happen in the liver. The usage of glucose will happen essentially everywhere else. Okay. As a result of all this, that glucose being taken out of circulation and either being stored or used for energy, blood glucose levels are going to decrease as a result of that. And then insulin release will be inhibited as blood glucose levels decrease to normal range. Okay. So that's what insulin does in the body. And you can see down here, once again, number 6, you see that over here, negative feedback as insulin release is inhibited as blood glucose levels begin to decrease. Okay? Well, that's insulin. Glucagon is going to do the exact opposite. Okay, well, not the exact opposite, but close to the exact opposite. Okay, and I will say now, so my biochemistry professor in college always used to give this particular term to remember exactly what it is that glucagon does. And the term is as follows, is that glucagon is released when glucose is all gone. So glucagon, glucose, all gone. Glucagon, glucose, all gone. So glucagon will be released when glucose levels are low. Okay. And that's going to be the stimulus for glucagon being released, is a decrease in blood glucose levels. And just remember, glucagon, glucose, all gone. So that's what we have here in step number 1. Alpha cells in the pancreas will release glucagon after detecting the decreased blood glucose levels. Again, a humoral effect. So we have no hormones stimulating the pancreas here. In the liver, glycogen is broken down. So here we have the exact opposite of what we had going on in what was going on with insulin. Okay, so with insulin, glycogen was being built up because we had increased blood glucose levels. Here, we want to take those glucose stores of glycogen and break them down. In addition, new glucose is created. Remember, that is that process called gluconeogenesis. And the synthesis of glycogen is going to be inhibited. Breaking down glycogen in order to get glucose, we want to inhibit the creation of glycogen. In adipose tissue, lipids are broken down while the synthesis of lipids is inhibited. So we have the exact opposite of what we had going on with insulin. Blood glucose levels as a result of all of this will start to increase, and glucagon release will be inhibited as blood glucose levels increase to normal range. Okay. Please notice here that the effectors for glucagon are just the liver and adipose tissue, whereas back here, the effectors for insulin were the liver, adipose tissue, muscles, and pretty much every cell in the body. Okay. So much like PTH and calcitonin, glucagon and insulin will act in opposition to one another and also function to maintain blood glucose homeostasis. Okay. All right. This brings us to diabetes. Okay. I want everyone to, make sure that you pay attention to what we're about to go over on this slide because it's pretty important. Okay. I want to start off with the idea or the concept that the term diabetes, let me make sure that we get this straight, diabetes does not mean sugar. Okay. Diabetes does not mean sugar. Whenever we talk about diabetes, we're talking kind of by default about diabetes mellitus, okay? But the term diabetes itself does not mean sugar. What the term diabetes means is passing through or fluid loss. So passing through or fluid loss. That fluid loss can be due to either an ADH disorder or an insulin disorder. Okay? So an ADH disorder or an insulin disorder. If the cause of the diabetes is an ADH disorder, then we refer to that brand of diabetes as diabetes insipidus. So we talked about this earlier when we went through ADH. But if ADH is the etiology, we're talking diabetes insipidus. Okay, so this is fluid loss secondary to an ADH disorder. Diabetes insipidus can further be classified as either central or nephrogenic DI. Central diabetes insipidus is ADH deficiency from the hypothalamus. So this is simply where the hypothalamus isn't producing enough ADH, and as a result, you end up peeing a lot, and as a result of peeing a lot, you lose excessive fluid. Okay, so that's central diabetes insipidus. Nephrogenic diabetes insipidus is where the kidneys do not listen to ADH. And they don't listen to ADH because most of the time the kidney is going to be damaged by radiation or drugs or what have you. Okay. So that is diabetes insipidus, fluid loss secondary to an ADH disorder. Okay. Now, if you have an insulin disorder, this is where we start to talk about diabetes mellitus. Okay, so this is fluid loss secondary to a insulin disorder. And here we start to talk about type 1 and type 2 diabetes. Type 2 diabetes is diabetes that we are all familiar with. Okay. Type 1 diabetes, this is an autoimmune disorder. This is when your body's immune system will attack itself, leading to destruction of beta cells. Remember, the beta cells are the ones that secrete insulin. So if your immune system were to attack those cells, you're going to have a complete loss of insulin. Insulin is absent in these individuals. Okay? And type 1 diabetes usually tends to affect younger people. Okay? So, if you see a diabetic-like picture in a 14-year-old, for instance, more likely than not, that's going to be type 1 diabetes. It is very, 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 very uncommon for someone that young at 14 to develop type 2 diabetes. Okay. So type 1 diabetes for the most part is going to be a disease of younger people. Type 2 diabetes, on the other hand, comes from insulin insensitivity. So looking at it in principle, type 2 diabetes is actually very similar to nephrogenic diabetes insipidus. In nephrogenic diabetes insipidus, the kidney's not listening to ADH. Here in type 2 diabetes, cells all over the body are not listening to insulin. Okay? So the insulin is present here in type 2 diabetes, but the cells of the body have become insensitive to it. And so what happens is, instead of that glucose being moved into tissues and being moved into the liver to be stored, it just sticks around in the bloodstream, and there it can wreak all types of havoc. Okay? So this is a disease of older people, because usually, things like obesity will cause the downregulation of insulin receptors and lead to this particular condition. Okay? So we have identified, I'm just going to put arrows by them. We have one, actually, really particular about colors. So you have to excuse me. I get the right color here. So we talked about 1, 2, 3, 4 different types of diabetes. 2 of them coming from an ADH disorder and 2 of them coming from an insulin disorder. Regardless of the type of diabetes that you are talking about, all of them, every single last one of them, are going to share these characteristics of the central profile. That is increased urination, decreased body fluid volume, and decreased blood pressure. All of these here, central nephrogenic diabetes insipidus, and then type 1 and 2 diabetes mellitus, will have increased urination, decreased body fluid volume, and decreased blood pressure. Okay? That's what they all have in common. But again, the term diabetes does not mean sugar, it means fluid loss. And that fluid loss can either be due to an ADH disorder or an insulin disorder. Insipidus is ADH, mellitus is insulin. Okay. Okay, more on diabetes. So we again learned that the pancreas will secrete two hormones, insulin and glucagon. Diabetes mellitus is characterized by a high blood sugar level over a prolonged period of time. Okay, so this is what we refer to as a chronic disorder because it takes years in order to develop. Now we have three types of diabetes mellitus. You have type 1 diabetes. This is juvenile onset, meaning that it occurs in younger people. It can also be referred to as insulin-dependent diabetes mellitus. And what that means is the presence of type 1 diabetes depends on the absence of insulin. I'll say that again, okay? So type 1 diabetes mellitus is referred to as insulin-dependent diabetes mellitus because the presence of type 1 diabetes mellitus depends on the absence of insulin. So here, insulin is absent because of that autoimmune attack, and you get the central profile symptoms. Again, this is going to be more prevalent in younger or juvenile individuals. Okay? Type 2 diabetes mellitus is adult onset, so this is going to be older people. And this one is called insulin-independent diabetes mellitus because the presence of type 2 diabetes mellitus is not dependent or independent of the absence of insulin. So that's type 2 diabetes mellitus. So this is the one associated with obesity and sedentary lifestyle and bad diet and et cetera, et cetera. Okay. And then number 3 is gestational diabetes mellitus. This is diabetes that develops during pregnancy. Okay. And actually, gestational diabetes mellitus is actually so common that just part of routine prenatal care is that in week 26 of pregnancy, you are actually supposed to be tested for gestational diabetes. So every pregnant woman is tested for that particular condition because that can lead to issues with the growing baby, inside that pregnant woman. In the U.S., 90 to 95% of diabetes cases are type 2. So type 2 diabetes is by far the more common type. And it's so common that almost everyone knows someone with diabetes. And if you don't know someone with diabetes, you know someone that has diabetes. Okay? Very, very common. Most common sign or symptom of diabetes mellitus is weakness related to a low energy state. So these individuals are going to be very fatigued. Okay. However, the primary symptoms of diabetes you will see in addition to that low energy state include polyuria. This is excessive urination. Okay. So remember from before that central profile, we have increased urination. Okay, so that is consistent with what we said before. The polyuria will lead, well, actually, let me park here real quick. So the excessive urination will occur because of the excessive glucose in circulation. And why did I use the highlighter there? Not mean to do that. So essentially what's happening is the glucose is present in the bloodstream. It makes its way in to the urinary system, and the body figures it can eliminate the glucose if the body just pees it off. Okay, so that's why you get that polyuria. Polyuria will then, well, actually, we'll get to that in a second. But the second primary symptom of diabetes is polydipsia, which is excessive thirst, and then this occurs because you're peeing off so much fluid that you're going to be extremely thirsty, and you're going to need to want to sorry about that, to replace that fluid that you peed off. Okay. And then lastly, we have polyphagia, which is excessive hunger. And this comes about because, remember, you have glucose that is floating around in circulation, which means that glucose is not being used by different cells and tissues around the body, which means that different cells around the body do not have an adequate fuel source. So because the glucose isn't available, the body will start to use fats and proteins for fuel. And as a result of that, the individual will become very, 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 very hungry. Okay? So essentially what's happening here is the polyuria causes the polydipsia. Okay? The excessive urination will cause the excessive thirst. All right. Other symptoms of diabetes may include unexplained weight loss or gain, blurred vision, that is because of what we call sorbitol deposits in the eyes, nausea, slow healing wounds, and tingling in the hands. This one here, the tingling in the hands, that's pretty serious. Okay, so patient is complaining of that. That means that we have some case of full-blown diabetes that is not being adequately managed. Okay. Diagnosis for diabetes. Generally, a family history of diabetes or symptom onset prompts people to be tested for this disorder. Diabetes can be diagnosed by using one of the following modalities. Okay? So number one, we have the blood glucose test, which is where we have a blood glucose level of 126 milligrams per deciliter or higher after an 8-hour fast. Okay, so that's the one that is commonly used to diagnose diabetes. You do a blood glucose test, and this tests for the level of glucose in the blood. It has to be following a fast where you're not eating, so you know what your body looks like in the absence of food. The second test, it's a glucose tolerance test. This one is the one that is used on pregnant patients. So this is what they are tested for at 26 weeks gestation. And here the person's blood glucose is measured 2 hours after drinking a liquid that contains 75 grams of glucose. So if you think the best way to describe this substance that the patient has to drink If you think about like Kool-Aid, think about how sweet that is, and if you eliminate as much water as possible from that Kool-Aid, so it's more like a sludge. That's what this substance, you know, is like. That's what it tastes like. It's very, very, very sweet and very, very nauseating, to be perfectly honest. Okay. A blood glucose level of 200 milligrams per deciliter or higher after a glucose tolerance test is positive. And then lastly, we have the hemoglobin A1C, which measures average blood glucose over a 3-month period. So a good way to describe this, the blood glucose test is kind of like a snapshot in time, what your blood glucose looks like on a particular day, at a particular time, at a particular moment, whereas the hemoglobin A1C is more like a video. So that's giving you information from a long period of time, okay, usually 3 months. And here are, hemoglobin A1C levels. Normal, you want to be less than 5.6. This is pre-diabetic, and then this is diabetic. So, all right. Okay, a little bit more on type 1 and 2 diabetes. Again, type 1 diabetes, autoimmune disorder in which the immune system attacks and destroys the insulin secreting beta cells of the pancreas. Condition is hereditary. Destruction of these cells will cause insulin production to decrease or stop altogether. As a result, blood glucose levels can rise from the normal range, 70 to 105 milligrams per deciliter, to dangerously high levels exceeding 500 milligrams per deciliter. Okay. Type 1 diabetics will receive insulin through several injections given over the course of a day. Infected individuals can also monitor their blood glucose through the day with a glucometer, and also regulate their blood glucose through the use of an externally worn insulin pump. So again, that's type 1 diabetes, autoimmune disease, happens in younger people, destruction of beta cells of the pancreas, leads to decreased insulin levels and increased glucose levels. Okay. Type 2 diabetes, again, the pancreas is secreting insulin, but the body's insulin receptors are downregulated because of obesity, because of sedentary lifestyle, because of bad diet. All of those things can lend to the development of type 2 diabetes. That phenomenon is called insulin resistance, when the body doesn't listen to insulin. Okay. Insulin-resistant receptors will take up glucose even when insulin is present, so blood glucose levels become elevated. So again, notice here that blood glucose levels are elevated in both type 1 and type 2 diabetes, but they're elevated for different reasons. Okay. Insulin resistance is associated with obesity, I said before, physical inactivity, family history of diabetes, and old age. So older individuals are going to develop this condition. Treatment will involve adopting a healthy diet, adequate exercise. So those are your more conservative treatment regimens. You can also give these patients oral hypoglycemic agents. And if the condition is severe enough, you can actually also give them insulin. And the idea here is to bombard the patient cells with as much insulin as possible to kind of force the patient's body into taking up insulin so that glucose levels can come down. All right, so that's type 1 and type 2 diabetes. All right, the gonads. So the gonads, again, are the paired oval testes, cased by the scrotum, sac located outside the body. They produce sperm and testosterone. Testosterone will be responsible for sperm production, development of the male reproductive system, and secondary sex characteristics like pubic hair, deep voice, increased muscle mass, etc., etc. Okay. The ovaries are located inside the female pelvic cavity. They produce eggs, estrogen, and progesterone. Estrogen will be responsible for regulating the menstrual cycle, also promoting breast development of the female reproductive system, and secondary sex characteristics in the female. Okay? So those are your gonads. All right, so let's end by talking in this video by talking about the minor endocrine organs. So here we have the thymus gland, which we're going to talk about first. So again, that's going to sit on the anterior aspect of the heart. Large in infants, grows until puberty. Will start to regress after puberty. Produces thymosin, thymulin, and that should be thymopoietin, not thymoprotein. Sorry about that. So thymopoietin is what should be here. And of course, as we said before, this will mature T lymphocytes, otherwise known as T cells, which we see over here. Okay. Next, we have the kidney. Endocrine cells will synthesize and release erythropoietin. Okay, and erythropoietin is a hormone that will stimulate the red bone marrow to increase RBC proliferation. Okay, so erythropoietin comes from the kidney, stimulates the bone marrow to produce more red blood cells or erythrocytes. RBCs are oxygen-carrying cells, of course. Okay. So far we have thymosin from the thymus gland, erythropoietin from the kidney. From the heart, endocrine cells here will synthesize and release atrial natriuretic peptide, or ANP, very fitting, produced in response to the walls of the atria, those are chambers of the heart, being stretched. ANP will increase urine output and dilate blood vessels, which will lead to a decrease in blood pressure. So that's the purpose of ANP. The liver is going to release insulin-like growth factors in response to growth hormone. Will also release angiotensinogen, which is part of the renin-aldosterone-angiotensin system. And this system here will function to increase blood pressure. Okay. So the renin-aldosterone angiotensin system, that will be activated when blood volume or just body fluid volume is low. And as a result of that, the system is activated, and that will cause increase in blood pressure response to that low body fluid volume. Okay. Stomach and small intestine. The stomach will synthesize and release gastrin, which is a hormone that increases stomach activity and digestion. The small intestine will release secretin and cholecystokinin. Secretin will stimulate the release of bile from the liver. We'll learn more about bile later, and digestive and pancreatic enzymes. This will help to break down food. CCK or cholecystokinin will stimulate the release of bile from the gallbladder. Okay. So bile is actually stored in two places, the liver and gallbladder. Those two hormones will modulate the release of that substance from both places. The skin, so ultraviolet light will penetrate keratinocytes to convert modified cholesterol to vitamin D3, also known as cholecalciferol. Vitamin D3 is then activated to calcitriol by two organs, the liver and then the kidneys. Calcitriol is an analog to parathyroid hormone. So it's going to do everything that parathyroid hormone does. It will stimulate the release. So everything that parathyroid hormone does, is these three items here. So you have increased calcium release from the bone, decreased calcium loss from the urine, and increased calcium absorption in the intestines. All of this to increase calcium levels. And then finally here, we have our last slide for this video. Adipose connective tissue is located throughout the body and releases leptin. What leptin does is it will bind to receptors located within the hypothalamus to inhibit appetite and thereby reduce food intake. Overeating will cause more adipose cells to be formed, and hence leptin is produced, suppressing further appetite. Okay? So if leptin is present, the appetite will be essentially reduced. If there is no leptin signal, then that is going to promote hunger and eating as a result of that. Conversely, periods of starvation will lead to a reduction in adipose tissue, and hence less leptin is released, triggering hunger. So again, leptin is absent, you get hunger. Leptin is present, you are satisfied. As obese people are constantly producing higher levels of leptin, their body becomes progressively desensitized to the hormone. That means that they are more likely to feel hungry, less likely to recognize when they are full, and hence more likely to overeat. Okay, so leptin can be pretty dangerous. Leptin resistance also develops with age, increasing the potential for weight gain later on in life. All right. So this concludes video number 7. Next video, which will be the last video for the endocrine system, we'll go through hormone interactions and the stress response. So, see you guys in video 8. Thank you so much.